morning, good afternoon, good evening, good night, all of our dear colleagues and friends of the noble profession of dentistry. Today, we have two wonderful guests, we have one wonderful guest and a wonderful host, Dr. Atala, whom we recently introduced as a region and board member of our organization of this peer-to-peer platform, and Dr. Mirela Feraru from Israel, very well-renowned clinician and artist that has joined us. We are very honored. Thank you guys both for coming on.
Thank you.
Thank you.
Good morning, everyone. Today,
just a quick before we get started, Dr. Atala, I just wanted to give a quick some housekeeping things. In terms of registering for CE, if you want a CE unit for a session, please go to gi-summit.com. You can watch the session obviously live on our Facebook page. Today, we have one more good news on Mother's Day, and we all sort of conspired to bring Dr. Ferraro on Mother's Day when we hit 500,000 dental professionals and reach them from all over the world. So thank you, and happy Mother's Day also, Dr. Ferraro, as I disappear into the dark.
Thank you, Kenan.
You're very welcome. Hang on one second. I am going to go ahead and please, Dr. Atala.
Perfect. Good morning, everyone. Today we have a very interesting speaker, like Dr. Shah said. It's Dr. Mirela Feraru. Everyone in the implant field already knows her and knows the kind of work that she does. And we're very happy to have you, Doc, and happy Mother's Day as a start. I'm going to say a little bit about Dr. Mirela. Dr. Mirela Feraru is a DMD, graduated in 2005 from the Faculty of Dentistry in Timisoara, University, Romania.
Mm-hmm.
In 2009, she joined the Chashu Clinic team in Tel Aviv, Israel, and for the last 10 years has gained in-depth knowledge and experience in all fields of the perio-prosthesis and aesthetic dentistry. Her outstanding clinical achievement focusing on complex restorative and perioplastic surgery treatments has positioned her among the top emerging stars in the world of dentistry, and everyone knows that. Dr. Ferraro publishes clinical articles into international professional literature and lectures worldwide on complex aesthetic restorative treatment and interdisciplinary perioprosthetic concepts and treatments. She has also authored the bestseller book, Dental Visualizations, published by Quintessence Publishing in 2019. Dr. Mirela, it's an honor to have you today. We're very excited to see what we're going to be learning, and welcome and happy Mother's Day again.
Thank you. Thank you. Thank you very much, Joseph. It's really a privilege for me to be here, and I really want to congratulate you all for this amazing achievement. And I'm sure that behind this is a lot of work and dedication to such an amazing project. So really,
Thank you.
Congratulations. Congratulations.
Thank you.
So, Joseph, I think that we will start, right?
Yes.
You can see, Kianor, you can see my screen now? Joseph, is everything okay? I can start, right?
Yes. Give him 1 second. Yes, he's showing it now. Perfect.
Okay.
Go
so,
ahead.
like you both said, thank you very much for this really kind introduction. Of course, it's good evening, good morning, and depending whoever is watching, wherever, from which corner of this world. And I must say that this type of online type of lectures, webinars became in the last 6 weeks something that is our habit, which we didn't think about it 3 months ago. But I guess this allows us at the same time to maintain contact and create new connections and new relationships with people, even in such a far distances, and even in a larger number like we were used to in the general congresses. So basically, I would like to start and to share with you in the coming 45-50 minutes some concepts that we implement in our private clinic in Tel Aviv. Now, when we look at such images of 3 different smiles, and I guess that we all have different ways of appreciating and deciding what factors actually decide and makes a smile beautiful. But overall, when we look at it, we see that there is a nice harmony. There is a pleasant feeling of health and well-being of these particular persons. Now, of course, if we ask our patients what is their main interest when they are seeking dental treatment, it's actually very simple. The majority want to eat as good as they can. They want to smile and feel very comfortable with their smile, and they want to be able to speak and express what they want to transmit to the other person in a very natural and healthy way. And now if you take a look more closer of how all these three different patients arrive to our office, we can understand that they all have undergone a more or less complex restorative and prosthetic treatments. Some of these teeth we couldn't save and we had to be replaced with implants. But overall, it doesn't matter what the actual treatment was. What is important in the final result is this harmony. If we look at the interface between the natural structures, which are the soft tissues, the hard tissues, and the artificial one, either if we refer to our crowns or veneers or our implant-supported restorations. And what we actually aim is to try, and our drive is to get the best possible quality in terms of the final result for our patients. And of course, not always is possible to get the ideal result. And I would like to emphasize this during my lecture, that this is not about ideal. It's about a harmonious result. It's about our concentrating our forces and aiming to provide beautiful, as close as possible to a perfect result as Mother Nature has created for that patient. So I will talk a little bit tonight about managing the perio-restorative interface. Actually, this interface between the teeth, our restorations, and the soft tissues that surround them in the aesthetic zone. And as I mentioned, I will concentrate on natural dentition for tonight. Just as Joseph mentioned it, I'm living for 12 years now already in Israel. And this is the small team, but which I'm very lucky to be part of, together with Professor Nitzan Bichacho and my colleague, Dr. Galit Talmor. And of course, we are surrounded by an extremely talented team that goes from our secretaries, our reception front desk, to our hygienists, to our assistants that support us. And actually, our results basically are due not only to our own involvement, but also to the team approach that we believe, and each and one of the persons in this team gives its input in the final result, for which we always appreciate and thank them each time. Then, of course, Nitzan, Galit, and myself, we always have, we believe in of course, in an interdisciplinary approach. But more than that, we believe in the importance of discussing and analyzing cases. So as you can see here, many times we sit and we try to decide what is actually the best way of treatment for our patient. And this, of course, takes times and hours and dedication. As you see here on the right side of your screen, for those that watch this presentation on a computer, you will be able with your phone to screen the QR code that you see there. And you can download whenever it appears the PDFs that are related to the specific articles that you will see that are incorporated in during the lecture. And for those at the end that were not able to do it at a certain time, just write down which one you were interested in, and I will make sure that will be provided to you. So any kind of, let's say, treatment planning, especially those that involve the high concentration in the aesthetic zone, will always start with the specific steps. And the data collection is one of the most important things, because it doesn't relate only to of course, the x-rays or images or videos that we are used to collect, but also gather a lot of information regarding the history of the patient. If he has been through any other dental treatment in the past, and what was the experience during this dental treatment, because this will have also an important impact on their approach and their, let's say, willingness to be involved in, let's say, a more or less complex treatment in our clinic. And this is important also from a psychological aspect to be understood. Of course, when we get an image and an idea about what we are facing, the second part will be, of course, the communication. The communication, again, we go first to our patient, trying to understand what exactly do they expect as a final result. Because here is also very important to lay it in front from the beginning, because sometimes the expectation of our patient do not meet with the clinical reality or the reality that we know that we can provide for that patient. Then, of course, all the information will be transmitted to our laboratory, which is our collaborator in all the cases from the beginning. We do not live now in the period that the dental technician enters the treatment at the part where the impressions have been already sent to the laboratory. A true team approach involves also the dental technician at the beginning. And we were going to see later on what is the importance of that, because we have to provide and we have to know from the beginning what will be the final design, what will be the final result that we would like to provide for that patient. And in this case, the wax up, the design on that can be digital or analog, it doesn't really matter. The approach, what it matters is that this design has to be established from the beginning, which means that the collaboration with the dental technician has to be already at this stage. Then, of course, when we have a design of a specific project, and here we can rely on many different also softwares as a help, I'm going to give some examples of that, then we are going to test drive this design, meaning that from the phase of the laboratory, which was the diagnostic wax up, we are going to transfer this into the patient's mouth before we even start the treatment by the procedure so-called MOCA, which actually gives us information on the final aesthetic result that we would like to achieve, on the function aspect, and of course we have to understand what will be the biological costs or risks for a specific procedure in order to get that final aesthetic result. Now, if you take a look at the simple situation like that, obviously the patient has undergone several dental treatments in the past. And then I will not take you in this case into details, but we arrive to the preparation phase and we look at the final result. I think that overall, besides the beautiful ceramic work of Stefano Inglese in this case, what actually catches the attention of the eyes is the natural response of those tissues when they surround something that is completely artificial. And I think that when we talk about biological integration and we talk about aesthetic results, we have to aim for a response of tissue health. We have to have an image that those structures are in complete harmony. So, of course, many times we encounter this type of clinical images, and we understand obviously that here we have some issues, first of all, regarding the crown margins and contours, as we can see here, a poor adaptation around those teeth abutments. Then, of course, this many times has an implication on the prognosis of those teeth, and many times when we remove these crowns, we find out that in the majority of the cases it will be very difficult to save these teeth. And then, of course, at the end, there will also be an influence on the soft tissues. So as we saw previously, that we aim for this type of integration, we have to also to understand in all of these three different interfaces, what is actually the impact and role of each one of them, and how can we control in the best way so that the final result will not end up such as this one, but as we saw previously. Now, regarding these three different interfaces, we have also three different questions that are related. So when we try to understand how can we be predictable, because the bottom line at the end for our patients, what they are mainly interested, besides, of course, the final aesthetic result, is how long it's going to last. They want to know during the years if this result is going to be stable. So in the controlling the interface, we have to understand, first of all, how to address the soft tissues. Then, of course, what type of abutment-related prosthetic decisions we will have to make. And, of course, last but not least, which type of restoration design and contours should we approach. So basically, my presentation will be related to one clinical concept that relates to the cervical design of those restorations. And we are going to see also the impact of this design on the soft tissues that surround them. Now, when we look at Mother Nature, and in nature you see everything as its best, and we look at tooth morphology, and we know there is a big variety in terms of the natural shape of teeth. But overall, if you take two main categories, which we know that they can be triangular or square, we actually see that this is not related only to the individual tooth shape. It's related also and has its relationship with the soft tissues. Because as we see here, A more triangular form goes with longer, slender taper crowns, and we have very delicate areas in the cervical convexities, as we see in the image on the left side of the screen. And the more squared teeth are, we see less scalloping of the soft tissues, but a more pronounced cervical convexity. And these are all anatomical features. Of course, if I would show you that actually on tooth number 21, this is actually a crown that we have to insert, we can say that overall we were very successful with the final result, because in this case, from a prosthodontic perspective, it's not very difficult to manage such a situation. We have to have a precise and accurate preparation of that tooth, correct relationship with soft tissues, and we are going to see later on the importance of that. Take an accurate and precise impression, but then the big, let's say, the amount of work that will come will be from our technician, in this case, Shlomi Silberstein from Israel, that had to provide this restoration. Now, we saw before that we have, in natural shapes, we have different characteristics. And if we look at a natural tooth, we see that the cervical part, we can talk about an emergence angle that is around 15 degrees. And we can talk about different cervical profiles. For instance, this situation which is more straight or flat, but as we saw previously, it can be also more concave or convex. Now, if we look at teeth and our relationship between the prepared teeth and our ceramic restoration, so we see that we have an emergence angle, but what we are mainly interested is actually on the design and those contours of the cervical profiles. And here it's very important to be, let's say, concentrated on that, and especially our dental technicians, because we can influence. Because when we have the power to decide on this specific cervical profile, and this cervical profile will have an influence, as we'll see later on the soft tissues. So, for example, if you take this clinical situation, and these were two crowns we had to remove, but basically what I want to underline here is that when we have different type of restorations that teeth will have to receive, for example, combinations of crowns and veneers, it will be very difficult for the dental technician to reproduce the same optical characteristics of two different restorations that have different thicknesses and also have different substrates, and to do it from the same material, like in this case was lithium disilicate. The main issue is that we have different thicknesses. You can see here very clearly for a very minimal invasive veneer around 0.5, and we have around almost 2 millimeters, 1.6 for the crown. So of course that this will have an impact also on the interface relationship. We see here the teeth that were prepared, the amount of volume that was created between the soft tissue margins and the abutment and the preparation margin. And this has even a bigger impact on exactly the cervical profile that I talked before. You see here that actually these two restorations will have to give support for a different volume of tissue between the preparation margin and the gingival margin. And here it's very important because at the end, this will create a different perspective of these two restoration. And the aesthetic zone, we know that the contours of the soft tissue have to be, especially of the two centrals, be symmetrical. And of course, between the lateral and central also, we would like to have a certain harmony. So those restorations will look natural in the end, and the soft tissues will have a natural response surrounding them. So our clinical considerations actually are being based on a proper periodontal evaluation, meticulous prosthetic procedures, which relies on the preparations, taking impression, and all the other steps. And of course, the precise contours of those restorations, giving the soft tissue biotype and characteristics that we have in that particular case. So by proper periodontal evaluation, we mean that we will not perform any kind of prosthetic procedures unless we have complete gingival health. So we want to have no plaque, no inflammation, minimal probing, and of course no bleeding upon probing. And these are the initial steps, and for each our patients go through several sessions with our hygienist in order to not only to get to to a healthy periodontal status, but also to get them involved in a well maintenance phase, let's say. Because even after when we finalize these cases, the most important step is the recalls. Seeing the patients once in every 3-4 months for a general check, cleaning, and new instructions, because this is the way to maintain whatever we are able to achieve at the end. Now, in terms of the relationship of the soft tissue surrounding the teeth abutment, of course, we have different procedures by which we can change this relationship. Of course, we can do procedures such as crown lengthening, which can be either from a structural need or from to create more tooth structure for the preparation for those abutments, or either from an aesthetic perspective. We can cover the roots, of course, in those clinical situations where there is an indication by different approaches, such as tunnel approach or coronally advanced flap. And then we can restore the structures, those tissues, the position that we would like them to be. And of course, we can also increase the thickness of the soft tissues in the aesthetic zone, where we want to hide a dark color of the roots that many times transfer through thin soft tissues. So we have in our armamentarium different techniques and solutions in order to reconstruct or restore the natural harmony and architecture of the tissues surrounding our natural abutments. In the preparation management, there are many things to discuss, and it is very difficult to summarize things in around 45 minutes. But two main dimensions are important to be mentioned. First of all, our apical extension of our preparation margins within the surrounding tissues. And here is one aspect of the biologic width that we have to be aware of. And of course, there is the horizontal dimension or horizontal extensions, which have to do with the over and under contouring of those restorations, as we previously mentioned, and also have to do with the amount of tooth structure that has to be removed and the color of that tooth structure that we have to prepare. Now, for example, if we see this type of clinical situation, tooth number 11, we had to replace that crown, a tooth that has been already pretty deep prepared. We do not want to create any kind of violation of the biologic width and change anything in the preparation position. But in this situation, we will have to be very careful of how do we contour and how do we design that part of the crown that comes in under the soft tissue margins. Meaning that a very important step is already at the provisional stage. So our approach in the majority of the situation is to use this type of acrylic shells, as you can see here, that we reline intraorally with an acrylic material. And you see that we mark with a pencil the contours, actually the position of the soft tissue margins where we would like them to be. And remember, we mentioned that our restoration can be over or under contour, and this I mentioned that will have an influence on the position on the soft tissues. So in this situation, we have to control everything that relies beneath this mark that we created with our pencil. This means that we have to take care of this cervical profile, which we call it supportive cervical profile, because we do not want to change the position of the soft tissue margin either in a coronal or apical dimension. So we reline it with the acrylic material, and we see here we mark with all the area that is under our mark with the pencil. It's going to be as smooth as possible, in order to create a profile that will just give stability for the soft tissue margins. Will not impinge them in a more apical direction, will just give support, because we would like to create the same architecture and the same position as we have surrounding the tooth number 21. And there is always one aspect that I like to mention very much in this slide, is that when we look at the soft tissue response, although these are provisional restoration, we can see a beautiful stippling of the tissues. We can see that they are in a healthy situation. So as long as we work, even in very deep preparations, as long as we work very precise and respect the soft tissues, we will get a healthy and a positive response of those tissues surrounding even provisional restorations. So once this is done, it is very easy to go through a definitive restoration that the technician will provide. And you can see here, of course, we go through the traditional cementation. This was an adhesive procedure under rubber dam and so on, in order to get this to be clear, to be sure that we are following correct procedures. And then the final result will be, as we can see here, even in a way it looks better than that area of 21. Now, I mentioned before that we can, under and over contour door restoration, will have an influence on the positions of the soft tissue margins. So if you think now, this biologic response of the tissue to in which manner, to what it depends actually. So it has a strict relationship with the connective tissue thickness. And I talk about the connective tissue thickness that we find between those two epithelial layers, which is the intrasulcular one and the extraoral epithelial one. Now, these slides are courtesy of Dr. Roberto Pontoriero. Late Roberto Pontoriero passed away, unfortunately, almost 3 years ago. And this actually shows us very clearly what happens in this little area with the soft tissue margins the moment that we might insert a restoration that has an improper cervical profile. So if we have, this is the amount of thickness and that we have of the connective tissue, and let's say that we insert a crown that is slightly over contour. Now, we saw this many times in a clinical situation, that the first thing that happens is a blanching in the area, meaning that the first response will be always vascular. In other words, there will be an ischemia on this particular area. Ischemia, in other words, that particular area will be deprived of blood supply. Now, in this, from this point on, the tissues have two alternatives. If we are in the situation of a thick tissue biotype, meaning that we have a sufficient amount of thickness of this connective tissue, they will be able to regain the vascularization from the surrounding areas, and we will be able to maintain those tissues at this position. Now, if we are in the situation of a thin biotype, that means that those tissues will have to regain their vascularization in a different position. So they will just migrate more apically, and actually that very thin part of the marginal tissue will go through necrosis. And the clinical aspect of this, or the clinical result of this, will be gingival recession. So when we talk now about the horizontal dimension, this over and under contouring, now we understand actually what happens with the tissues. And we are also strictly related to the amount of tooth preparation. We know that the darker the tooth is, the more we are going to have to prepare in order to create, to be able to create a final aesthetic result that would be pleasing, in order to be able to give for our dental technician sufficient amount of space to build his ceramic work. Now, of course, this article published by Coachman, Galib Gurel, Marcelo Calamita, and it exemplifies very well the relationship between the change in color that we will have to perform and the amount of tooth preparation that we'll have to perform. So, of course, the moment that we have no need to change the initial color with the final restoration, we are in the most, let's say, favorable situation of almost no preparation. So we can be very minimally invasive up to 0.3, 0.5. Now, an important aspect, if you look at this slide, you will see that the more we have to prepare the tooth, the more the darker the tooth is, and the more change we have to give in terms of color. Not only that our preparation moves from a very light chamfer to a more heavy chamfer, but we also move in an apical direction. So if, let's say, in a no prep or minimally invasive approach, we can stay even supragingival, in a darker situation, we are going to go more and more intrasulcular. And this will have an impact, as we saw in the previous case, on the cervical profile of that restoration, because the volume in this area that dot restoration will have to give support, it is completely different. So as you hear very clearly, one central incisors are two centrals, 11 and 21. One was prepared for a crown and one was prepared for a veneer. You see the difference, not only of the preparation design, but also what I mentioned before, that air space, the volume that those restorations have to be filled, it is completely different. So the profile of this restoration, the contours and the location will be different. But what is important to understand is that the final aesthetic result, the final shape to our eyes has to be similar. Although these two restorations have completely different substrates, have completely different surrounding tissues, volume volume that those restoration will have to fill in. So regarding our crown contours, we are completely related and dependent on the soft tissue biotype. And this is an important aspect that also dental technicians have to be aware when they design those restorations. And if our dental technician was not able to create a proper cervical profile, and we see that we are in a situation of a thin biotype, and those restorations are too over contour, we have to be able to see that and correct that clinically, because otherwise, if this is not wanted, if you do not intend for an over contouring in order to change positions of the tissue slightly, as we are going to see in some clinical cases, then we are creating a damage to those tissues, and we are in the situation where a gingival recession will appear a few months or up to a year after those restorations will be in place. So many years ago already, 1994, Nitzan published the cervical contouring concept. And in this article, he described two main important zones. When we look at our restorations related to the teeth that are being prepared, we talk about the interproximal areas that have different characteristics than the mid-cervical ones. He called it the interproximal one, were called the pressure-absorbing ones, and the mid-cervical part was the pressure relief. Now, as the words are mentioning to us, in the interproximal area, somehow the tissues are able to take an intentional over contouring of our restoration. And the area that we should be very careful in not create any damage to the periodontal structures is the cervical part. Now, this aspect is very clearly being underlined when we talk about space dentitions. So when we try to close spaces, like in this case, these were the teeth already that have been prepared, the relationship between the position of the preparation margin in relationship to the soft tissues for a correct final design of those ceramic veneers is very important. Because one thing that we will not want to have in a space dentition situation is a black triangle at the end. The patient will not be happy by a beautiful ceramic work if at the end he will have spaces still close to the soft tissue margins. So in this aspect, when we talk about the position of our preparation margin, in this case, we're a very light chamfer. So in the mid-cervical part, that's number 3, that area of pressure relief zone, we want to stay also supragingival. We are in the situation that we have a light color of the substrate, so we don't need to mask anything. We can stay very minimally invasive. So we can be supra or juxtagingival with our preparation margin. But we are staying in this position up to the interproximal papilla, because then we have to slightly become intrasulcular. Now you see at the bottom of the screen on the right-hand side, the typical traditional preparation, window preparation design for veneers. But if we will have such an approach in such a situation, we will end up with what I previously mentioned, a black triangle with the final result. Because when we close spaces, an important aspect is to position our preparation margin interproximally, not only slightly subgingival, but also to go towards the palate. So it is more like a wrapping design of those teeth, but like a 3/4 veneer and not a traditional window preparation, because we have to give the possibility for the technician in the interproximal area to have an intentional over contouring of those restorations. Because that cervical profile in this area will be critical to be able to close the gap and change the profile of the papilla that it's actually flat from a more scalloped one. So remember, anytime we have to change a shape by a ceramic restoration, or we have to close spaces. We have to have an approach that positioning the preparation margins intrasuccular, interproximally, and also go beyond the contact point towards the palatal aspect. So we created for the technician the possibility to have the space to create an emergence angle that will allow him to have a cervical profile that is over contour and give support for the tissue in this area. So you can see here, these are the main critical zone. As we see here, the position of the preparation and the soft tissues. The interproximal one is the critical one because this will be the one that will allow us to have to be successful or to have a failure with the final result. And you see here already restoration in place. You can see very nicely that we are already in the situation that we have a scalloping of the soft tissue. These are 2 years restoration and function. These were lithium disilicate, actually monolithic, was one of the first cases that we did with the paint, glaze and stained only with Vincenzo Musella. But the important thing is to follow this cases during the years. And you see here that actually at 3 and 7 years, you see that the tissues look even more scalloped, more sharp, more defined. So I can say that after 6-7 years in function, we were really happy and satisfied with the final aesthetic result, and more important, with the stability of this final result. And I mentioned at the beginning that predictability is the thing that our patients are more interested in, and what we would like to be sure that we create a situation that will be stable over the years. Now, the same thing in terms of the concept of how to contour and how to design our restoration, we are facing also when we talk about pontics. Because when we restore a situation with, like in this case with bridges, and we have a pontic side, we would like that area to look like a natural tooth. We would like that restoration to have the image of a tooth coming out from the tissues, and not something that is overlapping, not something that will catch the eye that this is not natural in this area for that patient. So in this situation, what is important to analyze? If you can see here, this was the initial situation. The patient arrived after some small orthodontic treatment that he performed. And then we decided with him to stay with give him a final prosthetic solution, which will be a bridge from the canine to canine. Because of different also considerations, like we can see very clearly the 2 central incisors were not at their best, in their best situation from a structural aspect. But now if you concentrate on the pontic area, you see that we creating an intentional wound with a round diamond burr. What we wanted to create is actually the possibility of the tissues to heal surrounding a design of the pontic that we created. So this was the first provisional restoration that we inserted for the patient, and in many situations, the first provisionals are not really based on, in such cases, they are not within the final aesthetic result, but they are just a transitional phase. We are concentrating more from a structural and functional aspect. And then when we have a good prognosis of the teeth, and we know that this will be the final design also of the final prosthetic work, then we concentrate more on the aesthetic aspects, on the final shape of those teeth. And here also there are many, many things to be discussed. And you can see here from an occlusal aspect that we were able to perform this without any additional in terms of soft tissue augmentation, because we had sufficient amount of volume of tissues from a buccopalatal perspective. So what we just needed to create is to create a situation that our provisional restoration will allow a perfect healing, a natural healing of the tissues surrounding a specific design that we created. Of course, we started with a deficient, for example, papilla on the distal aspect of number 21. The aim was not to create something ideal, but the aim was to create something that will look harmonious to our eyes, and to, of course, take advantage as maximum possible of the tissues that were available in this case. So we see, I think we were pretty successful with the final result. This was the laboratory work of Giuseppe Romeo from Italy. Zirconia-based restoration, and I think a nice integration overall of the entire complex. But we are not always facing a situation that we can take advantage of the tissues that are present. And for example, if we take a look of this clinical case, you might say at the first look, well, it's very similar with the one before. We have sufficient amount of tissues. Yes, in a vertical dimension. But I mentioned before that if we don't have a sufficient amount of tissue in a horizontal dimension, we cannot compensate for that just by using the tissues that are available. So if we take a look now from an occlusal aspect, we see that the deficiency that we are dealing is too big in order to be compensated only by a small manipulations of the tissues locally by our restoration, only by prosthetic means. So in this case, we will have to increase in terms of volume these areas. So go to a situation like the previous case where we have sufficient amount of volume, and then we can influence, design, push the tissues in the position that we would like with our provisional restoration. So this is the amount of volume that we go back to the same volume that we will have to recreate, to reconstruct, and we did this with 2 small connective tissue grafts that we inserted through a tunnel approach, a pouch technique. And then we you can see here immediately after the surgery already there is a change in the contours of the ridge at the 2 pontic sites. And then we provisionalize the patient. These are still the provisional type of like Maryland bridges that we use, and the final restorations that we will have for her, she's still with the provisionals, will be a single retainer adhesive pontic bridge. But this was this is still in the transitional. You can see that the tissues are still in the maturation phase, and we can later on still condition them if we would like to push them more cervically and so on. Many times in these particular situations, we are discussing with the patients any further aesthetic improvements, of course, in terms of the shape and size of the 2 centrals related to the laterals and so on. So now I would like to take you through 3 different cases that actually show that we have different options and different approaches in our clinical life. And it's not that we can give recipes or say that this should be the right and correct way to have a certain approach, but we have to understand and analyze each case individually and decide what will be the best approach for that specific case. So we can address center situation just by restorative means. As we are going to see briefly, we can have a combination of perio and restorative approach. And then, of course, ortho, perio, and restorative, more complex cases, which really relies on interdisciplinary approach. Now, certain situation, I would just like to take you briefly through the most important phases, of course, as always, the initial step, which is the aesthetic analysis. And we know that we always start with the position of the incisal edge. According to that, we are going to decide if the teeth need to be lengthened in an incisal direction or in a coronal direction and so on. So again, many criteria. We take function into consideration and so on. But briefly, what actually made the factor that was very important here to be analyzed was these discrepancies of the tissues between the right and the left-hand side. And this patient wanted to create, to be able to provide for her a final aesthetic result as much as pleasant as possible, even though if it means to me to have a compromise, but have it only restoratively without going into any kind of surgical intervention. So we said, okay, we can give it a try and try to understand how can we control the position and manipulate more or less the position of the soft tissues by having a proper preparation design. And then, of course, our dental technician will have to give us the proper contours and support for those tissues in order to create this type of architecture and form with our final result. So this was our initial design, because we always start with our project, as we mentioned at the beginning. And according to that, we understood that in certain areas, we have to stay completely flat or not impinge within the soft tissues and aim for even a small coronal migrations of those tissues. And in certain areas, because we are also in the situation of a thick biotype, we can be maybe slightly over contoured in order to balance these big discrepancies that we have in the position of the soft tissue margins. Now, if you remember also that we said that when we want to change shapes and we want to be able to create over and under contouring of certain restorations, we will have to break the contact point in order to allow the dental technician to create these profiles also interproximally. In such situation, here we had approached the upper and the lower teeth as well, when we aim also for changes in terms of the occlusion and also big changes in terms of the aesthetic result. We send the patient with this type of permanent diagnostic MOCA, meaning that according with the diagnostic wax-up, as you see on the left side of the screen, which is the designed and analogic approach in this case, of the final result, we transfer it to the mouth, as you can see here with the transparent silicone keys and composite. We actually bond it to the patient's mouth in order to test drive it, to really test drive it by the patient for a few weeks, up to a month. We don't leave them longer than that. And then once we have the approval of the patient in terms of function and aesthetic, then we can proceed with the preparation. Like Galib Gurel and Nitzan Bichat already published in 2006, that there is a big importance of this type of analysis and test drives of the final design in complex cases. You can see here the preparations that we did to those teeth, and you see that in certain areas we have the contacts open, and in certain areas we kept them as a traditional window preparation design. And this was the final result that we were able to obtain together with Vincenzo. And these were again IMAX restorations, monolithic at that time, beautiful restorations. And you see that the result, it is not perfect, but we didn't aim for an ideal result. But there is a certain harmony of the entire complex. So we managed to balance and for the eye to create a nice relationship between those restoration and the tissues in order to create this type of harmony. But more important is to look at these restorations over the years. And this is 6 years already in function. I can say that 6 years also, the restoration behaved very nicely, given the fact that they were just stained and glazed. And also the response of the tissues, because we were in a situation of thick biotype, we were able to slightly over-contour, control those restoration margins in such a way that we provided a nice architecture, nice form of those tissues surrounding our artificial material. Certain cases, of course, the final aesthetic result, we are sure that we can improve with a better ceramic work, definitely. But then we are encountering the problem of the need to reconstruct, actually, to bring back the tissues to their original position. So we have this recession on tooth number 12, and this approach, in this case, will be a periodontal and restorative approach at the end. But as everything we mentioned, and I will repeat this, everything starts from the model. It can be a digital approach or analog, but it starts from a design, it starts from the collaboration with a dental technician, in which we inform about the future, root coverage procedure, that this area, we know for sure that the contours of those restorations will have to be as flat as possible, not impinging and not creating any pressure of those tissues in this area. Then once the new aesthetic design, and we don't have time to go through all the steps, of course, we do a MOCA, we present it to the patient, we get the approval of the changes in terms of the final aesthetic result, and then we start to apply our treatment steps. And the first step will be to address the root recession. In this case, I went for a coronally advanced flap, like Professor Zucchelli's approach with a connective tissue graft. And then we waited for around, this you see in terms of the timeline, around for 3 months before we went on with the preparation. Of course, in the area of tooth number 12, we will be supragingival. We are in the situation that we have light colored tooth structure, so we don't need to be very deep intracircular. You see the provisionals, and again, you see the response of the tissue surrounding those provisionals, which are in place already 2 to 3 weeks. So if we are precise in these steps, the tissues will always respond in a positive way. Then we follow, as you can see here, correct traditional adhesive procedure with rubber dam, proper isolation, working in a clean field, being sure that we are going to polish those margins correctly, and create a perfect adaptation of those restorations to the abutments without any residual cement and so on. This was 1 month after the insertion, and then we know that slowly those restoration will look even better. This is the beautiful work of Stefano. These were also Emacs restorations, but he's a big fan of a layered technique. So these were layered, both by layered approach, and you see here a few months after the cementation, and this was one of my last controls 2 years post-op. And you see there is exactly the aspects that we previously mentioned. The response of this entire complex has to be as natural as possible. And of course, we are going to follow this during the years and see if we were able to be also to provide also stability, especially in the area of tooth number 12, where we provided that reconstructive therapy. So of course, at the end, the most complex cases are the most, let's say, demanding, especially in terms of the planning, but they are the most rewarding when it comes to the final result. And this, I must say, thank you to the team of Dr. Nicolescu Agastein Clinic in Bucharest, and especially to Lara Stangacilovic, which is the prosthodontist that I collaborate there in this case. And I saw the patient later on phase, already after the orthodontic treatment, but you can see here that the initial situation already showed really a complex starting point. So in this case, the approach was to go through an orthodontic, periodontal, and then restorative approach. But we mentioned before that we always have to consider the aesthetic analysis as our starting point. Because even if we perform an orthodontic treatment, this has to be guided by the restorative result. So we need to know where we would like to move those teeth, where we would like them to be in order to facilitate the restorative approach later on. And then see, in terms of the periodontal structures, what we can improve and contribute to the final result. So lips in repose, lips in smile, this is before the orthodontic treatment. We don't have a lot of time to get into details, but really canines in the position of the laterals, I think, is one of the most demanding aspects in prosthodontics, because of various reasons, very big roots of the canines, a lot of volume that these teeth occupy, and they have to be replaced by something that it's much more narrow and much more delicate. And then you see here the decidual tools, the bringing the premolars in position of the canines and so on. But so our considerations will always be based on an aesthetic result. Then, of course, taking into consideration the functional aspect and the changes that we will have to provide. And then, of course, understanding what will be the biological risk that we will have to assume, if any, in our approach. So you see here the initial and after orthodontic treatment, there is an improvement, of course, in the interdental relationship. They did a beautiful work in bringing those premolar in the position of the canine. But now, of course, if functionally we are stable, now we can redo our analysis. And if you see, we have initial design that we overlap, and we see beautifully that now the teeth are in the correct position. But sometimes, somehow, the proportions, the position of the soft tissues are not correspondingly. So after the orthodontic treatment, we redo our aesthetic analysis. We look at the tooth exposure. You see very clearly that the canine is still too long. We are happy with the exposure of the two centrals. So now we will have to analyze things more in depth of how can we reproduce a beautiful natural architecture of the soft tissues that will surround in an harmonious way and in a healthy response those future ceramic restorations. So we have now also a situation like in the space dentition. So we already know that in terms of the preparation, we will have to go beyond the contact points towards the palatal aspect. So prosthetically, we are aware of what type of preparation design we are going to have. We have light colored teeth, so we will not have to be very deep in terms of the position intracircular, only in the interproximal area because of the spaces. But the main issue will be now, how can we also correct this misalignment of the tissues in order to create a nice scalloping, and then a natural design of the soft tissues that surround. So we additive MOCA will be the one that will guide us. So again, the restorative will be the one that guides us also in the periodontal approach. In this case, Rebel was the software used in order to give us an indication for the future shape, based also on the personality of the patient. For those that have any questions, maybe in the Q&A we will discuss a little bit, because I know we are running out of time, but I'm close to the finish. So we see the change between the situation after the orthodontic treatment and after our intervention periodontally. So we actually, when we raised the flap, we just recontoured and reestablished the biologic space, that 1 to 2 millimeters, for those supracrestal fibers to reinsert. And also take a look that we had to perform also an osteoplasty of the buccal bone, because you can see that those canines basically consider them that they have to be laterals. So we wanted to smoothen the area to create a final form and architecture as close as possible to the natural, to a natural situation. So wherever we didn't have to remove any bone, we were not. So we actually concentrated the osteoplasty and the osteotomy only in the area of the canines, basically, and slightly interproximal for a proper readaptation of the flap after the surgery. You see here, I think it was close to two months after the intervention, the smile of the patient, and we already start to get a better aspect. Although those canines are not in the perfect shape of a lateral, but overall the smile of the patient somehow is not that disturbing to the eye. So now we are ready actually for the prosthetic phase. When we prepare those teeth, remember again, the interproximal areas in this case will be the ones that will create the main issue in this situation. So in this case, now we have to reanalyze this from a prosthetic perspective. Where do we position the preparation margins? You see they are very light chamfer. They are supragingival in the mid-cervical area. Sorry that I cannot point it to you. And then where you see the arrows, those are the areas that those preparation will go slightly intracircular and towards the palate. Remember, those future ceramic restorations will have to give support for the papilla and close the interproximal spaces. Again, later on, after the check, the traditional adhesion, correct adhesion procedure, rubber dam, proper isolation and cementation of those restoration. This wolfaspatic restoration created by Stefano Tonarelli, our collaborator for this case. And it was just actually a few months ago, and since the COVID situation, everything got messed up. So I don't have to show, I do not have a more recent picture because everything has been blocked. But overall, I say that in transforming, if you think that those laterals are actually canines originally, and I think that we were pretty successful in creating a harmonious result in terms of the shape of the teeth, of the final restoration, but also when it comes to the interface of those restorations with the soft tissues. So, you know, at the end, when we look at the smile of the patient, she was very pleased, and we were very pleased with the final result. And I think that when we talk about these three different aspects, tooth preparation, so the substrate, the preparation, restoration, and soft tissues, it is very difficult to separate them and describe them each one individually, because it is an interrelationship and one is influencing the other. But it's always very important in any kind of aesthetic analysis to understand what is the final goal of the treatment, what will be the functional issues that we have to relate to, and then decide if it's going to be an interdisciplinary approach, like in this case, and then prosthetically wise, what do we actually need in order to get for that final aesthetic result. So the challenge in this type of interdisciplinary case is actually the treatment plan itself. And later on, the execution steps are, it goes without saying. So in my, just to summarize in a few words, what we consider actually very important is a proper planning, as I mentioned before, based on a correct diagnosis. I mean, the diagnosis is very important, but then your decision to which way to go, it might be different, solutions, but the important thing is to recognize the problem, which usually is a very clear one. Then we have to define the final project, regardless of the approach that we are going to perform, the final design that we want to have, and we need to obtain also the, let's say, the approval of the patient is important before we even touch the patient. So our final destination, our final goal has to be established from the beginning. The structural and functional support is, of course, not something that it comes second or third. It has the same importance as the final aesthetic design, but based on that design, we need to understand what are the changes. In order to get to that final design, what do we need to do in terms of, let's say, occlusion, and in terms of periodontal aspects, and so on. Of course, the precision execution goes without saying, working magnifying glasses, microscopes, taking consideration all the advantages that we have in order to be very precise, not only ourselves, but also our dental technician. Because it's to get that type of response of the tissues surrounding something that is artificial can be done only when this is very, very precise, and we do not create any situation that plaque can accumulate, that bacteria can trigger any kind of inflammation, and so on. Provisional or final restoration, as we saw. And I mentioned several times that there is no recipe. We cannot say that in case of this, you should do like this or should like this. It's all about case selection, because each and our patients are individual, and they are so different, and not only in terms of their clinical findings, they are different in terms of their personality. There are patients that will not be suited to go through a complex orthodontic treatment. There are people or patients that we have to accept the compromise already from the beginning, because we know they will not comply with the treatment. So our selection of the treatment plan has to be very much individualized per patient, of what suits that patient. And also here, very important, that psychological aspect that I mentioned at the beginning, that has really a big importance of how the patient will behave later on during the next phases. So we believe and we know that results are influenced by materials, right? Also in implantology, in prosthetics, they have their own, let's say, importance. But more importantly, that the final quality of whatever we provide, it's strongly dependent on us, on the operator, on what the eyes see, the mind can process, but at the end, the hands have to deliver. And with this, I would like to thank you very much, and I hope I was not a lot over time. Joseph, you're with me? Hello?
Hello?
Yes?
Can you hear me?
Yes. Can you hear
Yes.
me?
Beautiful presentation. Amazing. Like, beautiful. The work and the art and the precision is very impressive. Very, very impressive. I have a few questions for you. I love the way when
Sure.
you mentioned we have to give room for the technician when we put volume on the proximal contour for the veneers itself, and
Yeah.
just gives the technician the chance for him to let the tissue slide, and this grip for the tissues to just start sliding down over the.
Yeah.
Do you always do that, or like in specific cases?
In space dentitions, and when not only space, but whenever we have to change the shape drastically of the teeth, we want to let the technician the possibility of having a working space. So when we want to close spaces, we have to give support for those tissues. So we have to go towards the palate. The more important aspect is the position, the positioning of the preparation in a bucco-palatal aspect. So if we stop with our preparation margin interproximal, he will not be able to do that. So many of the times we might leave empty spaces that the papilla will not fill in the gap.
Yeah.
There is always, sometimes this is also like a trial and error thing, because we also think how much those tissues can grow interproximally. And this is something that we also, we see also with the provisional phases and so on. But the important aspect is that we go interproximally beyond the contact point and we stop towards the palate. And this allows the technician to have sufficient amount of space, also to give support for the tissue, but also when we want to change the shape, to have the possibility to play with the ceramic material.
With the ovate pontic, do you always try to make sure that it's thin enough so the tissues can grow all around 360 degrees, or would you put an ovate pontic that will let the tissue slide just like in a C shape rather than 360?
Yes, more what we are interested in the buccal aspect than interproximal one, but the concept is the same. If you have sufficient amount of tissue, or if you do a connective tissue graft, doesn't matter, but you have a specific volume, you want to create a pressure which is crestally, but also slightly interproximal. So it will give this feeling, the illusion of a tooth coming out from the tissue and not something that is overlapping. But for this, we need a sufficient amount of volume of tissue. Here you can either have it initially, like we had it in the first case, or if you don't have it, then you have to create it.
From the vascularity perspective of the tissues, would you have it a little bit thinner and have the tissues to grow like the ovate pontic itself with the anatomy of it? Would you have it a little thinner so the tissues can grow all around it better? Or
what do you mean? The pontic, you mean?
Yes, if we're looking at the pontic from the top, would you make it a little usually thinner, or have it like an reverse X-shaped where it's a little thinner?
No, so it should. We do it usually more round, and we see then the pressure that it applies on the tissue. If we see that it applies too more pressure on the part that comes to the cervical, to the gingival margin, then we smooth it a little bit, so it will creep in a coronal direction.
Deepitalizing the tissues before that is very important, just to try to give this hemosomal.
We create this intentional wound in the tissues with a burr, and then in these cases also we are following them. Of course, we see the patient after 2 weeks. We see how the healing is, how the tissues adapt. So these are not. Yes, these are not situations that you do it and then go back straight directly to the impression.
What kind of materials do you usually prefer doing that with the pontic? Mostly zirconia, or what other materials?
For the provisional, or for the provisional, we use
final.
Final, it depends. In this case, I mean, in this case, such a bridge, we prefer to go with zirconia. If we had to go for a single retainer, like the second case, in the second case, it's going to be a single retainer adhesive bridge. In that case, it can be either zirconia or a lithium disilicate.
But for the reattachment of the tissues, do you usually prefer zirconia?
Zirconia. Zirconia, it's shown to be the best. Also, we know from implant dentistry, we get the best response for the tissues. But the most important thing is the polish. You know, when we talk about this response, how the surface is being polished, because then, you know, if you touch it with your burr and you don't polish it, then later on, I mean, you create. So,
with the very thin biotype, would you consider the same technique that we do with the implants and the provisionalizing the implant itself by making it very thin to allow the tissues to grow and then thicker the temporary afterwards, or no?
No, so with very thin tissues, if we are in a situation that we are afraid that we might have any kind of gingival recession following our prosthetic procedure, we might consider augmentation of the tissues to increase the thickness before. Yeah.
Beautiful presentations. Amazing. It's like beautiful work.
I'm sorry for being a little bit over time.
No, take all the time you need. I think everyone on Facebook is just is trying to watch this presentation. I'm waiting for more questions. If anyone have questions, please start typing them down. But I think as they share it more often, there will be more questions popping out, and later on you'll see it too as well.
Okay. I'll be happy to answer to anybody if they also write to me later on, or in any other format. I'll be available.
Perfect.
I saw one on the thread said, "Hello, ma'am. Can we advise gingival massage over provisional crown because massage generally promotes more vascularity?"
Massage?
What is your take on that?
I would like to try that.
Yeah, I'm not sure I understand the question.
I mean,
but we have a lot of colleagues from different countries, so I'm not sure if I understand the question. But I'll put it up here. Maybe you can make
I think he's referring to if you do it to evaluate more. So sometimes you can do it just by seeing and pressing to see the ischemia of the tissues and the vascularity of it.
Yeah, I mean, maybe it means like putting on weight and see if the vascularity, if the ischemia goes away. Usually, no, in implants we do like that. But you know, on implant restoration, we are in a different situation because there you have a mucosa that will anyway adapt to whatever you are going to create, because you have usually you augment, you have sufficient amount of connective tissue. that will adjust. In teeth is not always the situation like that. So usually when we see this blanching and we are in a thick biotype, I mean, we can more or less understand the situation. Then it depends on our need. If I want to modify the position of the gingival margin, I can over contour, but that's something intentionally. But if I'm on a thin biotype, I would never like to see this type of blanching of the tissues with the provisional restoration. And you know, in teeth, you are not so forgiving like in implants. For example, in implants, if you create a restoration that it's slightly too much pressing the tissues, you can reduce. Even if you come back after a few days and you remove, the tissues will readapt because the environment is different. But on teeth, once it's recessed, majority of the cases you will never get it back, the reattachment. So it's not that forgiving like in implant dentistry.
Any more questions?
Actually, we're kind of out of time here, Doc.
Sorry for being
wonderful presentation, amazing
wonderful
work.
presentation, no doubt. But maybe we can have additional questions posted at the bottom, and Dr. Feraru can get to them later and answer them.
Sure, you can write to me, everyone. I will be available for any kind of questions whenever. If you feel more comfortable also writing in privately, that's fine as well.
Unbelievable.
Massaging the gum with the fingertip. Somebody wrote here. I think the question really was massaging the gum. To do a massage like this, that it will come. No, I didn't try this, I must say. I believe that once there is a blanching and I'm in a thick biotype, I'm safe. But if it's thin, I don't think that the massage or whatever will improve anything.
One more question from my side. Do you consider the collagen into interdental papillas?
I heard injecting. I heard injecting the yes. I heard, never tried it and never felt the need to do that. I don't know what is the stability of something like that over time. I don't have a lot of information to tell you, but I know it has been described a few times.
Yeah.
We're
hoping for new literature for it. Amazing presentation. Thank you so much.
Thank you.
Beautiful presentation, beautiful work, and hopefully we'll see you soon live in our
anytime
symposiums.
You guys did a wonderful work. I mean, really.
Thank you.
On the dental community, this is a gift.
Thank you. Dr. Shah is like the most active dentist I've ever seen in my entire life. Just like
you're all servants of the profession at the end of the day. You're all servants of the profession. You know, the word docere comes from Latin, and it means to teach. In fact, all of us as doctors around the world, our job is to learn, to do, and then ultimately to teach. And that's what these 100 doctors are doing. And we have the opportunity to affect hundreds of millions of lives by getting this knowledge, this wealth of knowledge to our colleagues in the most distant places in the world. But I think that's obvious. We just broke 500,000 on Mother's Day.
Happy Mother's Day again. So.
Happy Mother's Day to all the mothers that brought us to this world to make this all possible. Thank you, and we look forward to having you in future programs, and thank you for your contribution to this project, Dr. Feraru and Dr. Tal.
Thank you. Thank you both very much. It was a pleasure.
Pleasure. Thank you very much.
Have a nice day.
Bye-bye.